Today is one of those days. It's like complaint day. I have a formal HR complaint, somebody complaining about somebody else being racially discriminated.
Oh, God.
Another HR complaint about bullying.
Oh, God. Are you, like chief or?
Okay. So it's like, it's great. That's why I spent half a morning on the phone, and now like they keep texting me.
Oh my gosh. Yeah, I was just, gave up the role of interim chief, so I know how
It's like,
that
that's
works.
nonsense.
You can come up. Why don't you come up? I'll talk to you. Okay, we're gonna get started in just a minute.
Where are you sitting, Rob? Sit on the side or that side? I'll balance it out with you. There will be boys over there, so they'll rebalance it. How would you feel about eliminating the VEPs and the EEGs from the late onset follow-up pathway?
Oh, totally fine. I actually think for the lowest kids do nothing except be aware and see them, and the high risk kids. I would, depends on how high risk they really are, but I would do MRI and nerve conduction, nothing else.
All of our bears have been abnormal, like the
ours have too.
IKDs,
Okay, let's get started.
more reliable.
Hi,
than-
can Anna hear?
Well, at least in the nanny grade. I think.
Can Anna hear?
Yes, we can hear you.
Well, it says that the host has disabled my video, so you cannot see me. That may be what you wish, but I just want you to know that that's the case.
Is this Dr. Provenzale speaking?
Yes, it is.
Hello. Give us a sec. While they're
I'm
doing,
having the same
Yeah,
issue.
there are a number of messages in the chat about it. So if you look at the chat, you'll see that there are others who cannot enable their video. Yep, says you cannot start your video because the host has stopped it.
so while we're working on that, the video for the Zoom folks, I'll just introduce the session. So this is going to be another panel discussion. This is part 3 of what we were kind of starting yesterday, when we're thinking about the follow-up. Primarily, we'll be talking about Krabbe disease, but also can speak about ALD as well. But the follow-up, particularly of children who have been identified on newborn screen, who are not in that infantile Krabbe group. And similar to ALD, the issues around trying to follow kids over time to evaluate for disease beginning, the starting of the disease process in terms of symptomatic disease. So that's what we're going to be talking about today. This is a very challenging thing, and it's very downstream from all of those cytosine cutoff discussions that we had yesterday in terms of the newborn screen, and thinking about what those cytosine cutoffs are going to be, especially for states who don't have established newborn screening programs. Because with the lower cutoff, we do get more patients who are in this middle bucket here. So I'll just give just a very brief, over maybe 5 to 7 minutes or so, hopefully, introduction to the follow-up pathway. And then I'll introduce our panel members here who are going to be leading a discussion about this. So this is a paper that myself and this excellent group of people worked on back in 2021, or published back in 2021. It was really over a number of years, at least 2 or 3 years of regular meetings and discussions to come to these consensus. So we have 3 major buckets that we want to classify babies into once we get back a positive newborn screen. The first bucket all the way to the left there is infantile Krabbe. We talked a lot about that yesterday. And those are going to be, of course, the kids who have dry blood spot cytosine over 10, and that we need to emergently work up. And we spoke a lot about that yesterday. The second, the bucket all the way to the right, unaffected, is when we get a referral from a state lab for a patient that essentially looks like they're a carrier. And sometimes it's a carrier plus, or usually, to be honest, it's a carrier plus enzyme lowering polymorphisms. And those patients don't require any further workup, but even getting those referrals back can be tricky for the families, because we have to make sure that our communication is very clear, very reassuring, and they don't have hanging over their head for many decades to come this idea that they might be at risk for the actual disease. I think that Dr. Matern spoke very well about how using referrals based on cytosine above a certain cutoff will significantly reduce or eliminate maybe the possibility of getting these referrals for unaffected patients. But the patients that or the kids that we are going to talk more about in this session is the middle group. So these are the kids that we identify who are at risk for late onset Krabbe disease. In the Krabbe community, when we have somebody in this situation, we tend to say that they're at risk for late onset Krabbe disease, and not that they have late onset Krabbe disease. In ALD, when somebody is yet asymptomatic, they tend to say that they have ALD, not that they're at risk for getting ALD, right, Dr. Pratimi? So it's just a little bit of a interesting difference. But so for these kids that are at risk for late onset Krabbe, we're talking about primarily on newborn screen, the kids with a dry blood spot cytosine between 2, hopefully that's the cutoff, 2 and less than 10. So in that intermediate group. And as we'll hear from some of our folks on the panel, we certainly do get patients within this, or kids within this group, that will come back on newborn screen. And then what do you do with those children? That's a big challenge. So you could see there, initially what we want to do is we want to get these children into the clinic reasonably urgently, not emergently, not within the next day. And really the urgency is more for the family. than medical urgency, but we don't want, this thing that's not clear to them hanging over their head for, 6 weeks while they're waiting to get into an appointment. So getting them in rather quickly and then getting the follow-up testing that is needed, which I'll go through in a moment. Thanks. So as we all know, we all heard yesterday, sort of the 3 big picture major pieces of data that we're looking for to make this classification is the cytosine level. And please don't get confused the levels on dry blood spot from the levels in red blood cells or erythrocytes, because the range is completely different. Measurement of the GAL-C activity in leukocytes to understand if it's within the range of what's been seen for other children with Krabbe disease, and then of course the DNA analysis or the GAL-C genotyping. So this will show you that the basic algorithm. And what you see here is, first of all, when you get the newborn screen identified positive, Ohio needs to determine the blood cytosine level urgently because they don't have that as part of their newborn screen. I think most of the other ones have cytosine, so obviously that would just be a part of the not New Jersey. Okay, New Jersey and Ohio. So if the cytosine is not done, that needs to be done very quickly, but usually we have cytosine. So if you follow this pathway here, which one of these? Down here, you'll see that this is if the cytosine level is either normal or in that intermediate range. Of course, if it's in the high range or over 10, then we're going to be in that infantile Krabbe situation. So we want to determine the GAL-C level in leukocytes. We want to be sending GAL-C genotype at that time. And then usually I am also adding repeating cytosine in red blood cells at this time, just to get that value as well. And that I've been doing that more since this was published, but I do think that that's helpful just to have that information. If the cytosine is normal, and especially if the GAL-C level is above the range where we usually see affected patients, then we're going to be considering this patient unaffected. The asterisk here is that certain states like New York State do genotype as part of the newborn screen. So if there is a normal cytosine level, but the genotype looks concerning for 2 pathogenic mutations, then that patient should probably be followed. But certainly in a state that just uses cytosine to make the referrals, that situation would not come up. So then we have this middle group here, and this middle group is for our intermediate cytosine. And the main point here is that when you have that intermediate cytosine, then you need to then subclassify. I don't know if we can move that little picture, but we could subclassify this patient into being either at high risk or low risk of developing Krabbe disease in early childhood. Okay. Sometimes this is abbreviated to high risk and low risk of high risk or low risk patients. That's actually not quite correct, because what we're really talking about is the risk of developing disease in early childhood. Okay, so the so-called low risk patients might be at higher risk for developing like adult onset disease, for example. But the reason why we make this difference in the classification here is because it's really going to impact how much testing we need to do in early childhood. And that's as far as we can do right now based on the genotype, which I'm sure if anybody has had to think about these different variants that we get back and try to classify them or think about them, that can be very challenging. And we can talk about that a little bit as part of our panel. So for the high risk in early childhood follow-up pathway, we know that the onset of disease, as we talked about yesterday, when it's at a very young age, so let's say late infantile or between that 1 and 3-year-old range, can be very rapid relative to onset at an older age. So we want to make sure that the clinical visits are fairly frequent. And that's what this is telling us, every 2 to 3 months for the first 24 months, then every 6 months till 5, and then annually after that. This is for clinical visits. And then this is a basic idea about how often and what testing we should be doing. So what we had decided as part of this consensus recommendation was to do MRI brain, nerve conductions, and repeat cytosine level for all patients. I think a lot of people are probably doing BAER as well, since that seems to have a lot of predictive quality. EEG and VEP is a little bit less clear, so we didn't put that on here as definitely needs to be done. And then the LPs are very invasive, or are not very, but they are invasive. So the amount of information you get from that might not be worth the test, depending on the situation. And we want to be doing these core tests every 3 to 4 months. Okay, every 3 to 4 months for the first approximately 2 years. And then we're going to be doing them every 6 months for the next year or so, followed by annually until age 12, et cetera. So the point here is that when we have these patients at high risk, we want to be doing pretty frequent testing early. And then last 2 slides here, the low risk follow-up pathway. So for these patients, we get a bunch of these actually discussed at our Krabbe Newborn Screen Council, that the genotype looks like, if anything, it would be somebody at risk for disease onset in the juvenile or adult age range. So we really don't want to be putting the children, the families through such frequent testing and visits at a young age. So here we recommended every 6 months clinical visits for the first 2 years, and then just annually after that, and a much reduced testing schedule. And this was sort of counter to what had been done in New York State before this time, which was just like a lot of testing for all of these kids, even if they were low risk. So here we recommended an MRI, nerve conductions, and a repeat cytosine by 18 months of age. But a lot of times we will even advocate for not even doing it that quickly if it really looks like somebody who is not at risk for early childhood. So you might not even have to do it that young. But that's sort of what was on our recommendation. And then it's sort of vague, but somewhere between 2 and 5 years, every 2 and 5 years, depending on risk level. So trying to kind of minimize unnecessary testing. So that's what we came up with. And we now hear about, I think that's my last slide, yep. And now we hear about these patients at our Krabbe Disease Newborn Screen Council, and try to, as a group, think about how we would classify them, what we think about the genotype, if we have it, what kind of testing strategy we want to do, what kind of communication we should be having with the parents and the children. And this is definitely a challenge. So we have our panel here to think about this and answer questions that you all have and discuss. So Dr. Fatimi, are you ready to introduce? Welcome, thank you. Dr. Kurtzberg as well. Dr. Margie Ream, I don't know if you've been up here before, so I'll just say that you were associate professor in the Department of Pediatrics at Nationwide Children's Hospital and Ohio State University College of Medicine, specializing in neonatal neurology, newborn screen follow-up, and leukodystrophy. And then we have a couple people joining us remotely. So Amy White is joining us, laboratory genetic counselor at Mayo Clinic Biomedical Genetics Laboratory, who has developed significant expertise in the genetics of Krabbe disease and has given us some great talks in the past on some of the gene variants. And Dr. James Provenzale, who is a professor of radiology at Duke University and did some really important early work in imaging classification of Krabbe disease, or imaging grading, I should say, of Krabbe disease. So thanks so much for joining us. And I'm going to turn it over to Dr. Fatimi to lead the discussion.
Thank you. Yeah, so I think
as a center where we don't have newborn screening yet for Krabbe disease, I have actually questions, and we unfortunately don't get our hands on these kids yet, and so therefore I wouldn't be able to provide any information on like what to do with these since we don't have them yet. Unfortunately, all the cases of Krabbe that we have had were already coming in symptomatic, way symptomatic and diagnosed. The one, before I start asking questions, I do want to share an interesting single case that speaks of why we need to have this conversation. So I met a 27-year-old lady a few years ago who's a physical therapist who at age 9 presented with vision issues and was seen by Dr. Sakubai Naidu back then and got the diagnosis of Krabbe disease. No, unfortunately, I don't have the genotype, but the Dave Wanger's report from back then said that there was a remnant enzyme activity of 2%. And I had touched base with Gustavo Mercaba, who had her fibroblasts, and he had seen that there was some mild, but it was felt that she was homozygous. Her MRI looked classical Krabbe disease MRI. She never developed motor symptoms, went on, became a physical therapist. So I think that just speaks to the challenge that we have with these later onset form of this disease. But the first question was to go around and from the centers that do follow these individuals and try to get an understanding of how many cases are we actually talking about. And I'm trying to determine what genotypes do we actually think are the ones that we should consider low risk versus high risk. And so maybe before we talk about the genotype, just talk about the number of cases in each center. I'm going to pass by Dr. Kurtzberg.
So I'm not going to talk about our center per se, because I hear about a lot of cases that are not that don't actually come to us, but I still interact with the family or the physicians taking care of those kids. And I think that estimates are that there would probably be 30-ish of these cases a year or so around the country. Joe, do you think, is Joe here? But of these kids with intermediate psychosine who have some abnormal mutations and are at risk.
It'd be about 25 per year.
RG says 25 per year, so I was close. That's way down from the original experiences before we used psychosine to really help classify these kids, where they were more in the hundreds, and it was a lot of kids who were just carriers or who had no risk of Krabbe disease at all. But these kids we're talking about now, we believe are really potentially at risk. And I think the critical group to identify is the ones who are going to have late infantile or early childhood Krabbe disease, where I don't know if you remember my talk yesterday where I showed the twins, but in that kind of a patient, if you catch them early and you treat them, it makes a huge difference for their survival and quality of life long term. I don't know any good way to really say who that is when we just have the newborn screening information. And I know we've got these risk categories and we're hoping our determination of those categories is accurate, but I think it's really hard to be sure about any one kid. And I know we have these testing schedules, and I think maybe some of them are a little ambitious. For example, I don't think the low risk kids need an MRI by 18 months of age anymore. So I would challenge I take ownership of the decision, but I challenge that decision and think we should revisit it. But I do think we have to, without making the families paranoid, and that's really hard, help them to understand that if their child has something abnormal in their development or some symptom that's out of the norm for pediatrics, that they should then be evaluated at that time. And I know we all know stories where kids had stuff happen, or they got called CP, or they had a seizure or something, and they didn't get evaluated quickly, and that's a mistake. Or somebody thought, well, they had an MRI 3 months ago, it's fine, we don't have to worry about it. That's not true. So I think we have to work on messaging and awareness and somehow getting the point across that these kids might be at risk for something. And we do have to have a heightened sense of awareness. But at the same time, many of them may be normal out to 10 years, 15 years. Amy is on the phone and she has definitely experienced knowing which mutations are, the ones that are less likely to be associated with disease in childhood. And we'll get to you, I guess, Amy, in a while, but you can't see me looking at you, but I'm looking at you. But there are other mutations where we just have no idea. And we're just in this never land. I'll also say that it looks like psychosine between 5 and 10 or 5 and not 10 is more worrisome than psychosine under 5 in the newborn dried blood spot in the limited data we have, but I don't think we have enough data to be sure. I'll stop there and then more to come.
I think communicating with the families in this period about low risk and high risk and what we even think risk is really tricky. And when I talk to these families, a lot of times I'm actually lucky enough to have a psychologist that will come in with me if I feel like that would be helpful in the conversation, and they can pick up on little nuances in the conversation where, they can be like, wow, family, you twitched your eyebrow differently. Do you have a question about what she just said? And that's definitely a luxury that we don't have for all of our patients. But just kind of an example of how tricky this communication can be. I think, distinguishing between the high and low risk is obviously our first step. High and low risk within the at risk for later, not in the first 6-12 months disease. I think one of the reasons behind having those check-in appointments for the low risk follow-up pathway was to keep them in the system, because families forget that they might be at risk for a disease and pediatricians may not have even really understood. So I think that for in a family in the low risk category situation, I would offer, would you like to continue seeing me every year or 2 years? Because I would love to continue to see you. But if they're driving for many hours and it's a family that has a great relationship with their pediatrician, maybe things are fine and they don't have to come back right away or in a year or two. But I think that every couple of year check-in was to basically keep them on the radar and keep Krabbe disease on the family's radar. We are talking about a small number of patients. And so for each individual center, if we could make a phone call to the pediatrician to explain what this all is, would be really helpful, especially if we're not going to continue to see them at a regular basis for the lower risk follow-up kids. I do remember clearly one specific patient that was going to be in the low risk, but still at risk category, and they did not want anything to do with continued follow-up. And it was that they were particularly, they had come to us for a second opinion from somewhere else, and everywhere along the way, they were quite disgruntled with hearing anything about Krabbe disease, even though it was really important for them to hear it. I don't remember what all your questions were, but that's my comments.
I just had another thought based on what you said, which is just that there's the kind of family that doesn't want to have anything to do with it. And then there's the family who may truly be low risk, who just can't stop thinking about it. And where it really, really, I think, interferes with their whole life and their whole relationship with their child. And it causes, a big mess. And it's not that we want to miss anything, but I think we also have to recognize that. And the families I'm talking about call everyone. Some of them insist on multiple assessments, even though they may not be recommended. Others, it's just a mess and we're not handling it well. I don't know how to handle it, but I do know that's one of the places we're causing probably more damage than good.
And there's actually some data out there on newborn screen diagnoses and how that affects bonding throughout childhood, throughout early childhood, at least. So even for the, false positives, and this is why, many of us are very sensitive to the idea of false positives, that false positive result or the at low risk but at risk result could impact family bonding, child bonding, parenting style throughout childhood. And so this is not a benign conversation to have.
I was just gonna ask in follow-up, what would you ever, not that I'm proposing that at all, I'm just asking, would you ever consider taking any action if the family just says, so say you have somebody who's at high risk and they say, we just don't want to deal with this. We don't want to have any testing. Is this can we say that there is justification then to, call child protection services or enforce in some form or shape this, or is this something that we really want to just get consensus and parental agreement? I'm wondering what others think about that.
I forget. So the question was, would we call Child Protective Services for a family that declined further follow-up on the at-risk pathway? And I forget who all was at my table last night for dinner, but I actually said, who would call CPS on a patient like this? And that's a question that came up, during like the I think during some of the technical expert panel conversations that many of you were in on for the evidence review. And if we feel like we have educated the family, we're not telling them they have a disease. They're telling them that they're at risk for developing. And I don't know, it's really tricky, but we have to respect autonomy too,
I would not call in Child Protective Services. I would work really hard to somehow reach the family and at least say, we're here. If this, or this happens, call us. But I don't think it's the kind of situation where you should call protective services, or that you'll help the situation overall if you do that.
Yeah, the way we approached this, we had a patient who was at risk for, was at high risk for earlier onset disease, but not infantile. And the family was no longer interested in sedating their child frequently to detect a condition that they didn't think the child was going to have. And the way we approached it, and I talked to our ethics team about it, was that if we were to diagnose this condition, we would allow the family to decline curative therapy. We would allow the family to decline stem cell transplant. So if we were to allow that, and that would be within the goals of care of the family, then it makes sense that we also allow them to not get screening MRIs. The screening MRI scans, the sedating every few months did not align with their goals of care, which was to blissfully enjoy their beautiful baby. And so the baby did ultimately declare themselves, and they were no longer eligible for treatment, but that aligned with what the family's goals were for their child.
And they didn't involve you anymore at that point. I guess were they mad, or were they blame it on you, or what happened? That was the end of it?
Yeah, these are a little bit sensitive topics because these are small patient numbers and this is confidential, this is patient information. They appropriately were referred back to us for examination, and there's lots of treatment that can be provided, supportive care, even if it's not curative. They were instructed that they're not eligible for any curative therapy, and they were okay with that, and that and they are managing symptoms on their own. I think they were appropriately disappointed. I think they were appropriately upset that their child developed this condition. I think they, I don't know. I don't know that.
I was just going to say, just real quick, not to repeat anything, at University of Rochester, we followed probably like 5 kids now. I think he's that right, that we've accumulated over the last few years. Yeah, of this group, I mean, for late onset, at risk for late onset Krabbe. And I think that if the children and families are followed, and there's really good communication, especially we have the luxury, I guess, of like being very reassuring about infantile Krabbe. If there's just really good communication and really good follow-up, I think that it can be the psychological injury can be minimized. I don't know that I know the exact nature of their psyche, but I do think that's the case. Although I've also seen at least 2 or 3 older patients who had been kind of classified in the old days, so pre-psychocene in New York State, and that was pretty tough for them because they just were really unclear that they were told that the risk was very low in a vague way. I had a patient, for example, who came back at 14 years old who developed myasthenia gravis, which is a different completely different neurological condition for those of you who don't know. And they came to me at 14 specifically because they had screened positive on the early New York State Krabbe screening. And we're told that she really was not at risk for developing the disease, but the parent was just so worried for all of these years that as soon as something happened, they thought it was most likely Krabbe disease. So that was like 14 years later. So you just have to think about that.
Wow.
So I was just gonna say, I have called Child Protective Services once. It was a child, I don't know if Camille was there. It was a child with ALD that had a lesion. So it was different because we knew the child had a lesion. The family had expressed that they wanted to move forward with treatment. And then just like fell off the face of the earth, and we tried calling their primary care, and it's a family that didn't have transportation, and we follow many members of this family. So we did reach out, and we did tell the pediatrician, because we couldn't get the mom, that we were doing this because we needed to help them get the help they needed. Now there's probably a better way we could have done it, but that allowed us to get the driving and this kind of stuff. So I'm not saying it was the right decision. They are still followed in our center. But just to give the one time I've called for this.
It's makes sense. I think what we're talking about the issue that if you are going to make a decision, or if you're going to do an intervention, if there is something up with these tests, that makes sense that then you would want to call that. That's a good. So my question is though, okay, so we're going to do every 4 months an MRI. What do you see in the centers that you are seeing these cases eventually presenting? What do you think are the earliest changes that you see? And when would be the timing for you to say, now we are going to do the intervention? So maybe we should have him.
Let's turn that to
It's probably an
our
MRI finding. So Dr. Provenzal, you want to go ahead and answer that?
Sure. Well, let me start off by saying this is one of the most difficult things I do in neuroradiology in 35 years. And I've worked closely with Joanne Kurtzberg. And fortunately for me, I saw a lot of cases early in my career and of course, a large number subsequently. So earliest findings. The newborn brain is extremely, the T2 weighted images are extremely difficult to make a finding because of a number of things. One, most of the white matter is bright. You're looking for bright abnormalities against a bright background, very tough. Even a FLAIR image doesn't do well. But the things that I have seen early on are bright signal next to the atria of the lateral ventricles, so the back of the lateral ventricles. Bright signal in the deep cerebellar nuclei, which usually is permanent. And then going back now 20 years before we were seeing the kids treated within the first couple of weeks at life, you know, I've seen natural progression. And usually it was the development of abnormal bright areas next to the brain, other sites in the brain ventricles, next to the brain ventricles, or sometimes more peripherally in the white matter. There are things in literature that say, you know, are very classic, but you never see them, like abnormalities in the thalami on CAT scans, and we don't even get CAT scans on patients. So some of the literature is outmoded. So that's what I look for. But it's a classic case of you really have to, Joanne and I have to talk about the case in order for me to interpret it, because then she'll know if there's something that I think is borderline that becomes more important, where I put more weight on it and she does. So those are the clues, but we've made numerous attempts to try to figure out what else we could do. And that's how I got very interested in diffusion tensor imaging, and we've used it to follow patients, but we don't have, the problem is the onus is really on the clinical team and the laboratory services to push a kid from not quite sure to we're really concerned about this kid. I hope that explained the complexity and some of the early findings that I see.
So is the MRI the first thing, or?
Yes.
The first of what things?
The question is more, I think, globally, it's when you do all these, when you do all the assessments, I guess one of my questions, more a clinical question, is like, what is the first thing that becomes abnormal in these kids? Is it the nerve conduction studies? Is it the MRI? Is it different? Because could be, for example, save a nerve conduction study if the MRI is truly the first thing that becomes abnormal?
No, I don't think it usually is. I don't think it usually is. It might be, but you know, I defer to Joanne on that. But my understanding is that often some other neurophysiological test is at least suspicious. But the MR, usually you can't see changes until 3 to 6 months, if you see them even then.
I think that the conversation is different if you're talking about a newborn picked up on.
Oh yeah, I was talking about newborns. I'm sorry.
Yeah, no, yeah, I think I'm just clarifying in general. If you're
Yeah.
talking about a newborn, picked up on newborn screening, you have one set of issues. If you're talking about a kid that is, say, at risk for development of later onset Krabbe, the newborn studies are going to be normal.
Yeah.
But the question is, I think we were talking about the Q4 month for the MRI for the high-risk kids, meaning at high risk for developing Krabbe disease in early childhood, but not infantile disease.
Right.
I don't know which becomes
Yeah.
abnormal first. I think kind of the MRI and the nerve conduction typically are abnormal together.
Yeah.
In the
Well,
kids.
so I'm sorry, maybe I misunderstood. So if we're talking about kids who are at risk for developing late onset or late, we're
Now
not
we're
talking
at-
about newborns anymore.
Yeah.
Oh, well, I would say then the first things that we see are, well, actually, it's the same thing. It's bright signal either in next to the atria of the lateral ventricles or some other location relatively near to the surface of the lateral ventricles. And sometimes it's within the cerebellar nuclei. It's not in the brainstem. It's not in the periphery of the white matter.
Hi, I was going to add, and I don't know whether this is a center-based bias, but from my experience, the neurodevelopmental testing, I noticed that you don't have that on your protocol. And at our center, all our kids are followed along with objective neurodevelopmental testing. And from my experience, I think the neurodevelopmental testing along with the neurological exam is usually a clue ahead of the MRI. And it's very hard to put neurophysiological testing, because if you think about the ABR and the VEPs, then there's no specific normative data in that 0 to 1 age group. So if you have one of that turns abnormal, I tend not to react, but keep a closer watch and bring them in sooner. But the neurodevelopmental testing, if you see a plateauing and on that testing, I think that's an early clue I wouldn't jump to transplant, but that's a very early clue and I bring them in sooner.
I think the unfortunate fact of the matter is that we just really don't know. This is why the long-term follow-up kind of database is so critical. And we need to keep in mind that HRSA is going to ask for a 5-year follow-up once Krabbe disease newborn screening is rolled out. So I think that's going to be really important. I think also just hearing about cases, over today and yesterday, is that patients present differently. And somebody said something about maybe, I think this was your case, the 8-year-old that got diagnosed and then showed up as a physical therapist in their 20s. It sounds like they had motor. Yeah.
Well, they had myasthenia gravis, it sounds like.
I feel like someone had mentioned to me a case where it was really just peripheral, like nervous system symptoms. So I think we just don't know. And if we're worried, we should do something to test the peripheral nervous system, do something to test the central nervous system. Developmental testing is one way to test the central nervous system, and imaging is another way. And if we can really demonstrate that the functional changes occur before the imaging changes, then it's certainly easier to, well, not necessarily easier, but less invasive to do the developmental testing. But with ALD, it's just the opposite. The imaging changes come first.
Yeah.
You know, what we're not doing though is systematically following these kids. We do not have a database. We have all these anecdotes, and the older I get, the less of them I can keep straight and remember.
Yeah. Yeah. So I have a suggestion.
Yeah, I know we're planning that, but I'm saying this out loud. I know Hunter's Hope wants to have a database. You need financial support to have the right kind of database.
Yeah.
We have to figure out, how we're going to identify these kids, enroll them, and get the data. And I think it's critical, but not only because HRSA wants it, but because we need to know. And hopefully over time we will answer some of these questions, but you're right. We don't know the answers right now.
So I have a suggestion.
Developmental testing is part of that data.
Sorry, Jeff.
No, that's okay.
Sorry about that. So I was going to say, if for the late onsets, especially if we don't have developmental testing as part of our protocol for follow-up, we wouldn't pick up early neurological signs. We wouldn't know whether radiology precedes neurodevelopmental signs, where that might be your treatment window.
Jim, you were going to say something?
Yes, well, it's more about future than present. There's obviously artificial intelligence is getting a lot of hype and it's used for many different things. But when I think of AI, I think of a computer program being able to see patterns that human eyes cannot readily see. And so I think artificial intelligence could, within the next 10 years, play a very good role for this. It could show us the early, by feeding in enough Krabbe cases and enough normals, we could develop at least a strategy or a preliminary understanding of what the first things are that will be evident. And also it could be valuable for looking at a new case and saying, okay, that one fits, that one does not. Now, we don't have that now, but now is the time when we could be building that or thinking about it, maybe writing grants and so on. That would be kind of like a moonshot, as Obama might have said. So I think that would be that. There's hope for the future.
I wanted to add one thing, or just mention, because we're getting a little bit low on time, I'd love to hear from Amy White. Now, we haven't talked too much about the state of genotype, and that's just such a huge component to us to even being able to classify or try to classify the patients to begin with. So I was wondering where you think we are right now with our ability to understand these genotypes.
Well, thanks for asking. I think that it's slow going, but what I've tried to do is get as much information, clinical information about patients who have had biochemical testing in our Mayo Clinic laboratory. And Dr. Matern, who's there with you, and I look over this data frequently. We talk about a lot of cases back and forth and how they compare to others biochemically and in terms of genotype, phenotype correlations. And now we have a good amount of data from patients who have had ongoing at least biochemical monitoring, and for those who have genotype information that have shared that with us. And so now we are trying to collaborate, and I think it's going well, with Joe and Carlos in the New York State Newborn Screen Lab, and with Dr. Rajan, Dr. Ganesh, and also Dr. Wenger to create some summary of what we've learned about some of the most problematic GALC variants, and also some of the genotype phenotype correlations. So we've been meeting for about 6 months on a monthly basis to talk about a few of these variants, which I'm sure are familiar to many of you there. The one that gives us the most trouble is, I'm going to use the amino acid nomenclature, is the P.T112A. This one is usually categorized as a variant of uncertain significance, and really has not been seen in any infants or children that we're aware of who have become symptomatic. But now there is a publication of an adult onset case, and we are aware of one other adult who is symptomatic, who's not in the literature, both of whom have one T112A variant in addition to a more severe pathogenic GALC variant. So that one seems to account for quite a number of abnormal newborn screen cases in the state of New York and other states as well for those kids who we've received biochem for. And then the other variants we're looking at are L634S, which is thought to be involved in individuals who have later onset disease, but there have been infants reported and also a recent case. And so the other caution is if you might think something is an adult onset or a later onset variant, but it doesn't mean that in combination with a more severe GALC variant that it can't cause infantile disease. So we've had a couple cases where the cyclocine is very, very elevated, over 50, between 50 and 100. And yet because of the genotype, some providers have said, well, we consider this high risk, we just don't know. And that's when Dr. Matern and I say, no, we do know. The cyclocine is very elevated, this child is affected. So I think it's just really important to revisit when you're doing long-term follow-up, revisit that genotype, not only look at the literature and look at ClinVar, but you can reach out to us in the Crab-Bait Council, you can reach out to colleagues, to the listservs, and make sure that you still know how those GALC variants are classified and if there have been any changes or new reports. The other two variants this group are looking at are the M117B variant, and then also the Y319C variant, which we thought might always be indicative of later onset disease, but then there's been a homozygous case where a child who had homozygous Y319C, in addition to one of those polymorphic alleles, or what we call pseudodeficiency, the I562T, did present in earlier childhood with disease. And so we know that a lot of commercial laboratories are now reporting out those polymorphic alleles or pseudodeficiency alleles when it is done on a child or an adult suspected of having disease. But there are a lot of questions coming from individuals who have had carrier testing, couples who are pregnant, where those laboratories that do expanded carrier testing panels do not report out these polymorphic alleles or pseudodeficiency alleles, and yet they may be very important to know to have some more information about the child. So I know that's a lot of information at once, but I guess I also want to end with this, that with variants of uncertain significance, It's uncertain because we truly don't know. We don't want to blow them off, especially for children who have had abnormal biochemistry like elevated cytosine. We do think there's a good role for monitoring, especially children with the red blood cell cytosine. It is more sensitive for these later onset cases. And yet at the same time, there are these variants of uncertain significance like T112A that really haven't been shown to cause disease yet that we know of in childhood. And there are so many parents in waiting out there who are concerned about their children. Thank you.
So I think this is just frankly calling for, it looks like we are redescribing natural history. And yes, but absolutely, we need this to be funded effort and longitudinally followed to understand better. And I'm still struggling a little bit with, okay, so when we see a subtle change in any of these testing that we are doing, including say developmental testing, how much of a threshold of an abnormality do you need to say, now it's time to go and let's do an allogeneic transplant, right? And so I think that's like, does it have to be two abnormalities? Does it have to be a significant change in one abnormality? Or, you know, when do you have a sense yet? Or
I mean, I've been there. Doesn't mean I know, but I've been there. I mean, with the New York twins, as we call them, they had more than one. When they became abnormal, it was two. It was the nerve conduction and the MRI, and then their CSF protein went up weeks later. So we had some indication, but their cytosine did not change, right? And it was 8. It was 6. It's 6 to 8, and it did not go up like you would expect. It's a bias, but well, 6 to 8 is not 70. I really think the infantile cases have the really high cytosine. I don't think the late infantile or the juvenile cases necessarily get high cytosine. They may get modest elevation, but not to the magnitude you see in infantile. But you know, I think it's both how many things are abnormal, you know, what's going on clinically, and what's the magnitude of the abnormality. I mean, if you have an MRI that's just no question, then I would act on that regardless of what other tests. Yeah. Oh, they had one known disease-causing mutation and one in the day.
So at that point, that was a low risk for late onset.
No,
right?
no.
No, that's low risk, right? Nice 2 to 10 cytosine and.
But they also had enzyme levels that were basically 0.
Low risk would usually be if the genotype looks like one that would have a juvenile or adult onset. If it's just a straight VU without any knowledge with
2 to 10 cytosine with what is that?
with a completely unknown, then
Yes.
we would have to put that in the high risk for disease in early childhood because we don't know if it could be.
So what is low risk for?
So low risk would be, for example, there are genotypes that have been described as causing disease, but only in later in life.
And the guideline paper says pathogenic in a VU with 2 to 10 cytosine is high risk for late onset.
That were.
I mean, I'm hearing that for the first time.
Yeah, I don't know if we're so specific because that.
Well, that's a problem. Yeah.
No, I mean, we're meeting every month and we're discussing it. I don't.
Okay.
I don't think it's a problem. I think we just
don't
are
have all
trying
that.
to figure it out.
Yeah.
Yeah, well,
I think when in doubt, we're erring on the side of following as opposed to relaxing the follow-up.
Yeah. It's
So
just
we get a
interesting.
bunch we've had a number of patients presented over the last year or two where we have a genotype where it looks pretty clear that if there was disease, it would be later in life. And we've had plenty of patients like that. We know enough about the genotype that would say, if this is going to cause disease, it would most likely be later juvenile or adulthood. And we would recommend the low.
I just
risk
want to be
following
clear
the
again,
right
2 to 10 cytosine, 1 pathogenic, let's say severe and a VU would be, the council would recommend close follow-up.
Right.
Of VUs that
Most
that
VUs
so
are- most VUs are benign, but in this case, you would
if we
recommend.
didn't know. Yeah, but if we had.
I understand you don't know, but statistically, most VUs
We had that
are.
like
But we're not,
T112A.
we're not in, we're not in a normal statistical situation.
I know, so the statement is that that would be a high risk with a VU. Okay, I just want to be clear about that.
Correct.
Okay.
Yeah.
Well, you can look at
The
calcium.
question is, are there other biomarkers?
Especially like the neurofilament light chain. I was just
Oh.
wondering, if there's been some other leukodystrophy that's now shown to pop up, which is easier to measure.
Yeah, CSF protein margins for its brain, but you have to do an LP. And it has to be a clean LP, not a. Yeah. I don't know if that's been studied. I'm not aware, so I don't.
So I just know in ALD, there's very promising data that in young kids, not in adults, but in young kids, that the plasma neurofilament light chain goes up at the same rate. So I'm not suggesting you use it, but so what we're doing now, I think hopefully many centers is doing that blood test with every MRI. And I noticed similarly there was one other disease that was presented today that the serum correlated with the CSF. It just might be easier because as you have more people trying to read these MRIs, it's going to get harder and harder.
There's no solid study on neurofilament and Prader disease.
So we're just asking about specifically neurofilament light chain. The answer was that there was no specific studies looking at that right now. I think we're out of time. Thanks so much, everyone. And
Thank you.
to our
Thanks, everybody on the
panelists on
phone.
Zoom.
Thanks, Jim. Thanks, Amy.
Thank you for the invitation.
Yeah.